Hello, everyone. I'm Brad Rovin. I'm a professor of medicine and pathology and the director of the Division of Nephrology at the Ohio State University Wexner Medical Center. I'd like to welcome you all to this program titled Lupus Nephritis, What are the New Approaches to Therapy? And we're very lucky. Joining me today is Dr. Maria Delera, and she's professor and chief of the rheumatology section at University of California, San Francisco. Welcome, Maria.
Thank you very much, Dr. Rovin. It's a pleasure to be with you here today. Until
recently, the management of lupus nephritis has remained unsatisfactory due to insufficient treatment regimens. But now we have 2 FDA-approved add-on treatments and many more that are in the pipeline. In today's discussion, we're going to review these newly approved drugs, take a deep dive into the trial data, and consider how the drugs may be used right now. Maria, before these new medications were approved for use in lupus nephritis, what's been your standard of care approach to patients with proliferative disease?
That's a great question, Brad. And before we had these new approvals, my standard of care was to use either a cyclophosphamide-containing regimen or mycophenolate mofetil, because we have significant evidence that demonstrates efficacy of both of those regimens. In terms of the cyclophosphamide-containing regimen, we have 2 options. One is the lupus nephritis regimen, which is a lower dose regimen of 500 milligrams IV of cyclophosphamide every 2 weeks for 6 doses, followed by azathioprine, or we have a more standard higher dose NIH regimen. My practice has been to use first the Lupus regimen if I'm going to be using a cyclophosphamide-containing regimen.
So how do you handle steroids? How has your idea of steroids evolved over the years of practice?
My use of steroids has evolved tremendously. So prior to the data that we'll be discussing coming up, I was using moderate to high dose steroids in all of my patients as an induction regimen for lupus nephritis. I think now we have significant evidence and data. We don't have to use those huge doses of steroids, but that was my practice prior to these recent data.
All right, so let's move on and let's now talk a little bit about these latest treatments that have been approved for lupus nephritis. So just by way of introduction, belimumab is one of the treatments. The FDA approved belimumab for non-renal lupus over 10 years ago. We have a great deal of experience with that medication. It's a human monoclonal antibody. It inhibits the soluble form of BAFF or BLyS, which is a B-cell survival and growth factor. And then the second drug that's approved is called voclosporin. Voclosporin is an oral calcineurin inhibitor like cyclosporin and tacrolimus, and it's structurally very similar to cyclosporin. However, it's more potent and has a better side effect or metabolic profile. For example, not causing diabetes like we see in tacrolimus, better lipid metabolism, etc. So let me throw a question out to you, and I'm going to be a little bit unfair, but I think this is really good insight. You're a rheumatologist, and you may not really be using calcineurin inhibitors as much as we do in nephrology because we use them all the time in the transplant population. So I'd like to sort of get a rheumatologist's view of the results of the phase 2 and 3 voclosporin trials.
So that's right. As a rheumatologist, I don't have a lot of experience using calcineurin inhibitors. But I've had to learn a lot about calcineurin inhibitors with the advent of voclosporin. The data, in my view, are very promising. And just to give an overview of the Aurora 1 trial, which was the phase 3 trial of voclosporin and lupus nephritis, there were, I think, 357 participants who entered the trial, international RCT, and participants came in with class 3, 4, or pure class 5 lupus nephritis were randomized to voclosporin or placebo on a background of mycophenolate mofetil with a target dose of 2 grams. So a lower target dose than what has been used in other trials. And then importantly, the steroid regimen was a novel regimen that was also used in the phase 2 voclosporin. It was a low dose regimen starting with 2 pulses of 500 milligrams each of methylprednisolone, but then coming down to 25 milligrams a day as a starting oral dose of prednisone, and then down to 2.5 milligrams a day by week 16. So an expeditious taper, and then patients stayed on that 2.5 through the course of the trial. The primary endpoint was at week 52. And strikingly, there were a greater proportion of participants in the voclosporin arm compared to placebo that achieved a complete renal response defined by a proteinuria suppression to less than equal to 0.5 and stabilized EGFR. And the delta, the difference between the voclosporin and the placebo arm was about 19 to 20%. So that is a very large delta for our lupus nephritis trials. And even at week 24, which was a secondary endpoint, there was a difference between voclosporin and placebo of about 12% in favor of voclosporin. I think some other important take-home messages from the trial. Number one, proteinuria suppression happened quickly in the voclosporin arm compared to placebo. So time to UPCR of less than 0.5 and time to 50% reduction in UPCR happened much earlier in the voclosporin arm, within 30 days compared to the placebo arm. And that is also something very different. And I think that speaks to the mechanism of action of voclosporin, that not only are we targeting directly T-cell activation, proliferation, differentiation, but we are also having an impact directly on the podocyte cytoskeleton by inhibiting degradation of synaptopodin. I think that podocyte-specific effect is why we're seeing that rapid reduction in proteinuria with this agent. And then secondly, when we look at subgroup analysis of the primary endpoint, and we look at self-reported race, we see efficacy of voclosporin over placebo in patients of non-white race and ethnicity. And that is very important because these are patient populations that are most impacted by lupus nephritis, severe disease, bad outcomes. So to see that, I think, is incredibly relevant for all of us. And the last thing I will say is that the Aurora 2 trial, which was a blinded extension of Aurora 1, which followed participants from the primary endpoint at week 52 for another 2 years. The interim results were presented at the American College of Rheumatology meeting last November out to month 30. And those data were reassuring that the EGFR was stable in the voclosporin group compared to the placebo. So we're not seeing a decline in EGFR in the voclosporin group. And that was a concern because we know that in transplant populations, there is a chronic nephrotoxicity with calcineurin inhibitors, which many of us rightfully are worried about. And so I think that the Aurora 2 data were reassuring in that respect.
It's really heartwarming to hear the rheumatologists use the word podocyte and synaptopodin. I mean, this is really now. It shows how well the two subspecialties are coming together. And I think you've hit every important aspect. I guess a little bit of discussion before we move on. Were you surprised at the efficacy for class 5 with the calcineurin inhibitor?
I was surprised. So what Dr. Rovin is referring to is that when you look at subgroup analysis and you stratify by baseline ISN RPS classification, you look at the pure class 5, the point estimate for efficacy was in favor of voclosporin, but it did not reach statistical significance. And so I think that was surprising to me because we would expect, based upon the mechanism and the pathogenesis of class 5, and particularly damage to the podocyte, you would expect that we would have seen a significant result there. So that was surprising to me.
Yeah, it was a little surprising to us as well, but I guess just sort of to, reassure the audience, a part of that is there were far fewer patients with pure class 5 enrolled in the trial. And, you know, class 5 has a different tempo. It really takes a longer period of time. And so grouping class 5 together in a large trial with proliferative disease may not be fair in assessing the drug, because the endpoint is usually common as opposed to staggered, and that may have affected it as well.
So Brad, I'm going to throw this back on you. So as a nephrologist, I doubt that you have a lot of experience with belimumab. So I would love to hear your thoughts on the belimumab data for lupus nephritis.
Yeah, well, that's really a fair throwback, Maria, and touche to you. I don't have a lot of experience. We did the BLISS-LN trial, and so that's where I gained my experience. And fortunately, we have a multidisciplinary clinic with the rheumatology group that treats lupus. So I haven't had to learn much until now. So the belimumab trial was really rather unique. When you think about it, it was the first 2-year trial where the primary endpoint was at 2 years. It was tried to mimic real life in the sense that it allowed the principal investigator at each site to choose the background therapy. And that background therapy was the exact therapy you started off this conversation, mycophenolate background or a low-dose urolupus cyclophosphamide background. The other really interesting design of this trial was that it actually chose to use something called the primary efficacy renal response as the endpoint, which was very much like a complete renal response that we use these days, but a little bit more forgiving, a little bit more leeway in the amount of proteinuria at the end. We didn't have to come below 0.5. We had to come below 0.7 as the UPCR. And the GFR was a little bit more forgiving as well. And so the top line of that trial was that the patients in the belimumab arm had a significantly greater response rate than the patients in the control arm. And that was about a 10% benefit. But when you dive deep into the actual subgrouping of the BLISS-LN trial, some very important things come out. And I think it may help us guide, you know, maybe how we use these medications. The first thing was we did look at subgroups by class, just like you were talking about. And again, the class 5 patients, and there were pure class 5 as well as class 3 and 4 in this trial, they didn't really show a benefit with the belimumab. And again, there were not as many as proliferative patients, so that's one of the issues, but even the point estimate was not very good in this particular trial. So that was one factor. The other important thing that I think was from the subgroup analysis was when we divided patients into those who came in baseline high proteinuria, which was 3 grams or more per day, or low proteinuria below 3 grams, really the best effect of belimumab was seen in the patients with low proteinuria. So I think those will help us talk a little bit about, you know, how we might think about these agents in practice. Now, on the other side of the coin, because this was a 2-year trial, we were able to track kidney function over time and flare, lupus nephritis flare over time. And belimumab, no matter what the background therapy was or what the class of the disease was, belimumab consistently decreased the LN flare rate in the patients in the trial compared to the control arm or the placebo arm. So that's a really important thing, because we know as flares accumulate, you have chronic damage to the kidney. The other thing that I thought was remarkable was that when we looked at the slope of GFR, so the slope of GFR is a way to see how kidney function is being maintained over time. A negative slope of GFR means there's a decline in kidney function. And in the placebo group and the belimumab group, the slopes were negative. But numerically in the placebo group, this was a much higher number than in the belimumab group, suggesting that the belimumab was in some way preserving or protecting renal function. So I think those are remarkable findings. As we explore these drugs and they're used in practice, we're going to learn a lot more about them. So, all right. So a little bit of background then, and then how, Maria, are we going to use these drugs in our day-to-day practice? So just to get your take of when you might use VOLVO or when you might use belimumab.
So we look at clinical parameters, and I think that in my view, there are certain patient characteristics that would have me reach for voclosporin first over belimumab. So for example, as you just mentioned, Dr. Robin, in a patient who comes in with high levels of proteinuria, nephrotic range proteinuria, perhaps that is a person who I would reach for voclosporin in, because the results in the belimumab trial did not look as promising in the patients who came in with baseline high degree of proteinuria. I think, the other benefit that I see with voclosporin would be the rapid reduction in proteinuria that we see. And so therefore, again, patients with high levels of proteinuria and you're worried about the morbidity of the high levels of proteinuria would be a good choice. Now, I think, in terms of belimumab, we know that the safety profile of belimumab is fantastic. We've had a lot of experience with it going back to its initial approval for non-renal lupus back in 2011. So perhaps a patient who it has been already shown to have, multiple infections, and you're worried about yet another infection in the patient, you're worried about how immunosuppressed they are, perhaps belimumab might be a good option in that particular patient. Perhaps a patient that has a lot of extra renal manifestations, rash, arthritis, in whom belimumab might have been indicated anyway, even outside of lupus nephritis, we could use it there. Although I have to say, I would love to hear your opinion. We don't know that the calcineurin inhibitor is not going to work in those patients, right?
We don't know how the VOLVO or other calcineurin inhibitors will do with extrarenal disease. And the truth is, a lot of our patients come in, if they have lupus nephritis, that's really the main manifestation of their lupus. Maybe some arthralgia and that sort of thing, but a lot of times they don't have a lot of the other things that you will see without nephritis. I think the other thing, of course, to consider is the patient in whom one more flare might be a problem, right? They're sort of already having chronic kidney disease, and another flare might tip them over towards end stage. I like the idea of maybe getting belimumab on board if I'm going to be able to prevent a flare. I also like the idea of getting belimumab on board when I want to, really preserve kidney function in a patient who may come in with some CKD. And I think, of course, if a person has severely impaired kidney function when they start, even the FDA label suggests that the use of belimumab is with a eGFR greater than 45. So those are some things to think about characteristic-wise for the patient. Okay, let's wrap up now with talk about monitoring patients during treatment. How do you predict, or how might one predict, how a patient is going to do with a medication? What do you look for?
So we know, it's a great question. We know from work that we did with post hoc analysis of the Aspreba lupus management study that early reduction in proteinuria, meaning a proteinuria reduction of at least 25% in the first 2 months of induction therapy, is associated with a good response at 6 months. And similarly, normalization of hypocomplementemia within the first 2 months of induction therapy is also predictive of a good response at 6 months. So therefore, those are kind of early clinical parameters that we can follow in our patients to help us understand if the patient's on the right trajectory.
Okay, and so maybe then, if they're not meeting those parameters early on, you should think about changing therapies or adding something on, is sort of what you're getting at, I think.
Yes, I agree with that. I think they're helpful for us. And one question I had for you, though, Dr. Rovin, I find proteinuria to be challenging. It is the clinical parameter that we have, that we follow. We all follow this as a measure of response, but we know that there's a discordance between level of proteinuria and what is seen on the kidney biopsy, mostly from the work that you've done with your collaborators. How did you think about proteinuria as a measure of response?
So it's certainly the best biomarker we have, but that doesn't mean it's a good biomarker. If a person has their initial lupus nephritis flare and they had otherwise a pristine kidney before that, proteinuria is a pretty good marker of what's going on in the kidney. Once you've accumulated some damage in the kidney, you don't know if the proteinuria is reflecting the chronic scarring or active inflammation, often a combination of both. And then it becomes much more difficult to clinically evaluate. And I suggest that we should probably think about using the kidney biopsy a little bit more often in centers where it can be done safely, of course, to look at the histology and help that histology help us inform our therapeutic changes. Okay, so we're going to wrap up now. I think I'd like to just really thank Dr. Delara for this wonderful discussion, and I'd like to thank the audience for participating in this activity. Please go on to answer the questions that follow and complete the evaluation. Thank you very much.